So before we jump into what is going to be a very exciting conversation tonight, I just want to acknowledge that even though we are meeting virtually, both my office here at the Toronto General Hospital, as well as the Canadian Doctors for Medicare office, are located in Toronto on the traditional territory of the Wendat, the Anishinaabe, the Haudenosaunee, the Métis, and the Mississaugas of the Credit. Now, something I just learned recently is that Toronto is within the lands protected by the Dish with One Spoon Wampum Agreement. The dish represents the land that is to be shared peacefully, and the spoon represents the individuals living on and using the resources of the land in the spirit of mutual cooperation. Now, to us here at CDM, this agreement captures our responsibility not only to the land, but to one another as well, which is certainly relevant when we talk about the future of our public health care and the ways that we can sustain a system that takes care of those working within it. So as you're all joining us from across the country from various locations, I encourage you to consider the traditional territories upon which you live and work. Finally, we must also recognize and underscore the significant and unjust disparities that Indigenous people continue to face today due to systemic racism and the ongoing effects of colonialism. At CDM, we are committed to working to reduce these inequities as part of our work to advocate for better Medicare. We're excited to shift our attention to our esteemed panelists and to the topic for the evening, which is health human resource planning. More specifically, how do we build a system that attracts and retains people instead of losing them? As previously noted, after some initial remarks from each of our panelists, we'll segue into what I'm sure will be a lively discussion and Q&A, where we welcome any questions you might have on this issue. So tonight, we are privileged to have three distinguished speakers with us, and I want to start off by thanking them. Dr. Isser Dubinski, Dr. Bourgeault, and Dr. Alika Lafontaine for joining us. So very first, I'll turn to Dr. Isser Dubinski. Isser, could you take a moment to introduce yourself and then set the stage for our discussion by walking through some of the main myths or misunderstandings about health human resources in Canada as you see it?
What I hope to share with you in the next couple of minutes is 10 what I will call uncomfortable truths about health human resource planning in Canada. And in the course of doing that, I think it's only fair that I share with you a couple of things. One is, as Devon has asked, my quote unquote credentials. So a brief bit of my history, my bias and my opinions around this issue of health human resource planning have been formed through clinical experience that has included very rural family medicine, which I did for 6 years, followed by a 25-year career as an emergency physician. And during that time, I was a department chief, a chief of staff of a large community hospital, and also the chief of emerge in a tertiary quaternary care hospital in Toronto. So some of my experiences and some of my bias around health human resource planning reflect experience in a variety of clinical settings and having both clinical and administrative responsibilities. After my clinical career ended, I spent 15 years working with a health consulting firm, providing advice and support in literally every province and territory in Canada. And a great deal of that experience had to do with health human resource planning. So some of my bias and experience comes through the lens of being a consultant. And latterly, my career has been devoted to full-time academia at the Institute of Health Policy in Toronto, where, again, this whole issue of health human resource planning has often percolated to the fore. The other thing that I will say is that my sense of what these uncomfortable truths are is rooted, obviously, in clinical experience, reviews of literature, academic experience, but I think important to share with you that much of what I will say is opinion, and some of what I'll say is fact, and I will try to make that distinction clear to you as we go through each of these 10 uncomfortable truths. So this is the first and most uncomfortable truth, and this is clearly an opinion, which is my belief is that there is actually no shortage of health providers in Canada. Now, important that you understand what I mean by providers. Providers are not physicians. Providers include physicians, but I'm also talking about nurses, physiotherapists, speech language pathologists, et cetera. There is no question that we have a fundamentally difficult distribution issue of health providers, but that's different than the actual numbers of health providers. The second thing I will acknowledge that there is major problem with specialist access. But one of the questions we need to ask about that is, why does that problem exist? Is this a human resource problem? Or is it a problem related to primary care training? Is it related to our failure to integrate non-MD professionals into integrated models of care? Or is it a function of specialist appointment scheduling, where we know, for instance, that there are patients who may, for argument's sake, have had an uncomplicated myocardial infarction 12 years ago, living perfectly healthy lives, and are still seeing their cardiologist every 6 months for routine follow-up, effectively blocking access to specialists who are providing what should be, in fact, primary care. Part of the problem, no doubt, is that we have yet to find the ideal primary care model in this country. In Ontario, as an example, we've been through family health teams, family health organizations, family health networks, et cetera, et cetera. But I think, in fact, we have an opportunity to learn from what I think are perhaps not completely ideal, but certainly highly functioning, highly efficient primary care models. And two of them that I would hold out as examples, and I won't delve into any of these in depth and leave it open to questions at the end, are, for instance, the CHC or Community Health Center model in Ontario, which has existed for a long time as an integrated model of care, a capitated model of care, but which has unfortunately been relegated to the quote unquote model for the poor, the inner city dweller, et cetera, or the Algoma Clinic in Sault Ste. Marie, which is a very integrated primary care specialist, laboratory, diagnostic facility that operates very efficiently and is very close, in my opinion, to an ideal primary care model. I believe that we have failed yet to create truly team-based approaches to care, particularly if our idea of a team is a core group of people committed to a single cause. I think that in general, when we talk about human resource planning, we do not use data or evidence-based or best practice models of care to create models of care to better inform health human resource planning. So, as an example, we continue to offer huge volumes of surgery in tertiary, quaternary, inpatient facilities, but have yet to capitalize on huge opportunities to decant a lot of activity to ambulatory care centers, which operate much more efficiently, much more effectively, much more cost effectively. And instead, we rely on typically ratios, one neurologist for every 20,000 people, one general surgeon for every 5,000 people. I'm just making those numbers up, by the way. But those ratios have never been validated. We make human resource decisions because of individual physicians' sense of fatigue and wanting to have less call, less volume of activity, or on income-based planning, which does not serve the public interest. This is one of my opinions, and it is a strongly held opinion, and I must admit that, but we have to avoid the temptation to solve our human resource issues by pilfering professionals from under-resourced countries. It is just my strongly held feeling that recruiting physicians from the third world to solve our problem makes the global health issues worse, and I will leave that for further discussion. I have to think that we have to fundamentally revise our models of training. If we want to solve the health human resource issues, we have to revisit how we allocate postgraduate residency training positions. We continue, for instance, notwithstanding ample evidence that birth rates are falling and the percentage of the population that's occupied by those in the age group 0 to 18 is falling and will continue to fall predictably for at least the next 10 to 15 years, while our population of the elderly is growing almost exponentially. And we know that the elderly are the greatest consumers of healthcare resources, but we continue to allow or encourage large numbers of postgraduate trainees to enter, for instance, the field of pediatrics, but have not expanded postgraduate training positions in the field of geriatrics. On top of that, so much of our family medicine models of training occur in tertiary and quaternary centers where the concept of the family physician or primary care is viewed skeptically at best, and that discourages those who might want to pursue careers as primary care practitioners from doing so. I think we have to stop at this time this endless expansion of medical schools and begin to focus more and more on well-entrenched, enforced models of physician responsibility and accountability. If we look, for instance, at the number of family health teams in Ontario that have signed contracts that oblige them to provide certain hours of service on evenings and weekends, but fail to live up to those contracts, that is a huge factor in what we perceive to be a health human resource shortfall, but in fact reflects groups who have failed to live up to the terms of a contract they've signed for the provision of service. We have no national health human resource plan. And if we are going to talk about health human resource planning, we need to bear in mind that there are some provinces, such as Prince Edward Island or Newfoundland and some territories, that don't have entrenched specialist tertiary or quaternary care services. And in order to plan effectively for health human resources, we need to have a national plan that ensures and guarantees that those who live in those provinces have equal access to those kinds of services. We have no integrated, coordinated, comprehensive approaches to the care of the elderly. As I've already said, this is the fastest growing group in terms of percentage of the population. It is the group in the population that has the greatest burden of healthcare needs. And instead of looking at opportunities to integrate care across the spectrum, from the community to the hospital, looking at opportunities to capitalize on things such as acute geriatric units and regional geriatrics programs, we have scattershot approaches that will never solve the need for access to care. And with that, I will stop and I'll look forward to your questions later.
Thank you very much, Isser, for getting us started with what are some very captivating thoughts. We will move next on to Dr. Bourgeault. Ivy, you can take a moment to introduce yourself and your work, and after that, we would love to hear your perspective on how we can and how we should include a gender analysis and perspective when talking about health human resources in Canada, including what you found in your research and something very timely that was just mentioned in the chat. So, Dr. Bourgeault, the floor is yours.
Great, thank you so much, and I really appreciate the opportunity to engage with you today. And I want to also acknowledge that I'm coming to you from Ottawa, the traditional unceded, unsurrendered territory of the Algonquin Anishinaabe people. In their language, I would like to introduce myself and thank them for the ability to live, work, and play on this territory. Kwekakene Shaba, Ivy Injanakazen, Ni Donamita, Ottawa U, Miigwech Kakanake. And that took me a long time to figure out how to say that. And I encourage everybody to try to speak. I actually had the incredible privilege of learning Cree, where I grew up in Marshland, Saskatchewan. So I thought everybody did. And so it's just taken me a bit more time to learn Algonquin. So just a bit about my background. So I am now situated in the Department of Sociological and Anthropological Studies at the University of Ottawa. I hold a research chair in gender diversity in the professions, having previously held a CIHR chair in gender work in health human resources, and a previous chair to that, the inaugural chair on health human resources that was funded by Health Canada. I was mentioning in the pre-conversation that I've been studying health workforce issues for about 30 years, and that's it's a fascinating topic. It's an area of particular frustration, particularly in the circumstances that we find ourselves now. So I do want to raise issues from a gender lens, and we absolutely need to take that into consideration. The health workforce is where most women work. In Canada, over 80% of health workers are women. That proportion is higher than the global average of 70%. Now, keep in mind, we have what we call a global or gender leadership pyramid that states that most of those representing the profession are male, those or who identify as male, and those who are doing most of the frontline work within the health workforce, including, as Isser mentioned, in long-term care, are women. We have, and I can count them on two hands, and not fully, the deans of faculties of medicine who are women, who have been women. So there are 8 in the history of Canada. There are 4 right now. That's 23% of the 17 medical schools. There will be 2 new medical schools, and we'll see who the deans are there. So my byline for my chair is gender always matters. Even if you don't find a gender difference, it always matters. So gender difference matters in terms of, in addition to 80% of the health workforce being women, that's increasing more for women than for men. So there's been increases in the number of providers, but that's headcount, right? That is not measuring capacity to deliver services. And I'll get at some issues about the challenges with the data. The representation of women in the different professions is quite varied. There are some professions that are persistently female dominated, in the sense that there are more women, or those who identify as women in those professions. Dental hygiene, midwifery, nursing. These are professions that, are well over 95% are women. So we see a lot of women going into medicine, into dentistry, historically into pharmacy, paramedicine. But we don't see a lot of men rushing in to become nurses and midwives and dental hygienists, etc. In fact, when you see a nurse, you typically call them a male nurse because you have to specify their gender in addition to their profession. So we have to kind of think about what these words mean. So that's why the health workforce is really very, very much gendered. We talk a lot about the gender segregation, not just in terms of leadership that I talked about before, but in terms of how we value the skills of those different workers and how the different workers work within each of those professions. So I know this is primarily an audience of physicians, and I think I would really want to, capture what some of the differences are. So for example, in addition to a leadership gap, we have a gender pay gap within medicine. I really want to refer you to work that Boris Kralj has been doing since he retired from the Ontario Medical Association. So there was some very interesting Ontario data that he presented in the Medical Post, but he and colleagues at McMaster University, Arthur Sweetman, Meredith Vanstone, who was a former student of mine, produced and published recently in Healthcare Policy, and I'm happy to put the reference in the chat, which shows that across specialties, family medicine and specialists, that women on average in the lower half of the billing range. So if you partitioned the billers for fee for service into sort of lower half and a higher half, on average in the lower half of the billing range, women are consistently 6 to 10%. They're billing 6 to 10% less. In the higher range, they are 15 to 20% less. So in the high billers, this is where you see the gender pay gap really, really increase. So those are some of the ways that the health workforce system is highly gendered. I want to pick up on some of the points that Isser raised at the beginning. I would agree. It is difficult for us to know whether we have a shortage or not. The term shortage doesn't have an operational definition. What exactly does that mean? I would also agree that typical measures that we have used, such as ratios, are very problematic because it assumes that the population is the same and it assumes that the health workers are the same, that the number of physicians and the population, that somehow magically that makes something. And so the ratios are a very problematic measure. Also, a lot of people use the OECD average, the ratio, as some type of gold standard. It is not. It is not a target. It is simply a mathematical average of OECD countries that have very different health workforce systems. For example, it'd be very difficult to compare Canada with the UK in the range of midwives. There are 100 times as many midwives in the UK than there are in Canada. So how would you kind of measure that out? So I want to kind of point out that these are problematic. In their place, we should have much more robust measures of capacity. Who is providing clinical services and what is their capacity to deliver services? And so surely, in 2023, we can apply, some measures to what is a full-time equivalent. And then we can also say, who is the population and how is the population different? And in fact, we actually have much better data on the population than we do on the health workforce. So I also want to pick up on this issue that we have no national plan. We definitely don't. We also don't have a national strategy. We haven't had a strategy since 2007. And even that strategy wasn't actually implemented. What I would argue, just to kind of enhance and embellish a little bit what Isser said, we need a strategy to create a structure and a culture for health workforce planning. And by a structure, we need to make sure that we have standardized data across the country. We have very little standardized data for physicians. That's, I find, quite remarkable. There's standardized data. Even the billings are not standardized. CIHI, the Canadian Institute of Health Information, has to adopt a variety of different types of algorithms to sort of match the billings across country in order to create the National Physicians Database. Medicine is the only profession that does not provide data to CIHI through their medical regulatory authorities. And so that's very interesting because all other regulatory authorities provide data to CIHI. CIHI has to purchase a data set from Scott's Medical Directory, which is essentially a directory to sell things to you as physicians. I find that perplexing. So these are things that I'm quite curious about. So that's the structure. A structure for planning is to have better data that's standardized across jurisdictions, ideally across professions, in order for us to plan by sector. Primary care would be a good one to start, and to plan interprofessionally, because that's how, healthcare work is undertaken. And a culture of planning. Planning is not a one-off. Planning is not a one and done. Planning is not set sail, and don't change your course for 10 years because you'll very much end up like the Titanic. So leading practices in health workforce planning is that they are evidence-informed, and that evidence needs to take into consideration gender. Gender not as a binary, but gender in all of its various levels. It needs to take into consideration racialized identity, Indigenous identity, and let me just speak for a moment. We collect no data on Indigenous identity of health workers. So how is it that we are going to respond to the calls to action to increase the complement of health workers if we don't collect those data? Like, that is egregious, if anything. We need to have evidence in terms of capacity, where people are, right? There are 3 data elements that are largely collected by CIHI for professions other than medicine, nursing, PT, OT, and pharmacy. And that's gender as a binary, province, and age. That's it. That level of detail of data is not data infrastructure for planning. So we need to understand the needs of the population and how those needs are changing. That we need demographic and epidemiological information. That's really important. We need to make sure it's across different professions and it's focused on particular sectors. Planning is different than just modeling. Modeling is quantitative, but planning is also qualitative. It's bringing people together to really understand what's happening at the coalface that the data aren't quite capturing yet. That's very important. You need to make sure that plans, this is why I would encourage a national strategy to create a culture and structure of health workforce planning, but planning has to be locally relevant. Planning has to happen as close to service delivery as possible, which means everybody needs tools in order to do that local planning, and we need to build capacity in undertaking that planning. It needs to be iterative. We need to constantly refresh this because there are going to be new things coming up, and there are going to be things that are no longer relevant. And there are going to be new people in the system, practitioners, as well as, physicians, but new types of practitioners as well. And so that enables us to create a system that is robust against uncertainty. It enables us to have early warning signs for what's happening. Canada, fluctuates from really like highs and lows about what's a shortage, what's a surplus. And again, we have no operational definitions for either of those terms, but we do know that we have these incredible waves that we go through. And we're not at the bottom of this one, I hate to say. The place to intervene is much earlier, an early warning system before things go awry. And I'll just finalize just a couple of more comments just to respond to some of the things that Isser raised. I think primary care is exactly where we should start, right? Here's some really interesting data that we've gathered. So we've been doing some interprofessional primary care workforce planning in Toronto. Again, that was an appropriate level. We have standardized data in Ontario across different professions. We've created some tools that really understand what the population looks like and what the range of health workers are available. And one of the things that we found is when you're looking across different neighborhoods in Toronto, those neighborhoods with the lowest attachment to primary care providers, whether that's an interdisciplinary team or a family physician or a nurse practitioner or other types of primary care providers, those with the lowest proportion of being attached have the highest proportion of presentation of symptoms to the emergency rooms that are non-urgent. Now, if that's not an indictment of a primary care system, maybe the statistic that over 6 million Canadians do not have access to a primary care provider. So that's particularly problematic. And, whenever we present these data in other countries, they find it quite perplexing that there's this level of unattachment in Canada and makes us, look like we don't have universal access, for healthcare. I would also encourage reasons why we should not be relying solely on international recruitment. Not only is it Isser's opinion, an opinion with which I share, we have also signed on to a global code of practice for international recruitment. And in that global code, one of the core principles is to collect better data for more robust planning so that countries could be self-sufficient or move towards self-sufficiency. Again, another bit of a problematic term that doesn't have a complete definition, but there's a principle that's in regards there. So I'm hoping with that, I'm happy to sort of pick up on any of the other issues, but just to summarize, gender absolutely matters. Gender matters within medicine, gender matters across the health workforce, gender matters to leadership, gender matters to planning, gender in addition to all of the other really important intersections in terms of racialized identity, Indigenous identity, et cetera. So with that, I will close and I look forward to comments and questions. Thank you.
Thank you very much, Dr. Bourgeault, for your insights there, as well as your comments. Next, we move to Dr. Alika Lafontaine. Alika, I'm sure that you're very well known to many here as the president of the Canadian Medical Association, but feel free to provide any other introduction that you'd like. And then we'd love to hear your perspective and to hear about the CMA's work with respect to this issue, particularly, as a national organization representing physicians. What is the CMA pushing for when it comes to health human resources? And what do you think the federal government should be doing to improve HHR planning on that national scale? So Dr. Lafontaine, the floor is yours.
Absolutely. So I bring greetings from Vancouver, the traditional territory of the Musqueam, Squamish, and Tsleil-Waututh, out here for the Canadian Physicians Leadership Conference. And I think, like many of those who probably logged into the webinar, you probably are a bit more confused about health human resources than maybe before you joined. And that is exactly where you need to be, because if you're actually in the conversation, it should be confusing because it is quite confusing. One thing that I really appreciate, Dr. Dubinski and Ms. Bourgeault emphasizing is just the arbitrary nature of the majority of what we're actually doing in health human resources. We don't track numbers. I was thinking when Dr. Bourgeault was mentioning about the ratios, who decided that a patient panel should be 1,250? What literally happened, if you go back to history, was someone thought, well, this is when things felt okay, so we're just going to divide the total number of the population by the number of family physicians inside an area, and then we'll use that as the ratio. And so I think for many of you who are struggling in the community through these issues, it feels very arbitrary because to be honest, it really is. And so I come here with, experience with a lot of medical organizations prior to the CMA. I was part of the Royal College of Physicians and Surgeons Council during the time when they switched over to competence by design. Healthcare Can, when they started really having a lot of these HHR issues, kind of hit them. That was the Hospital Association. Obviously, with the Canadian Medical Association over the past year, with changes that have happened with the health transfers and streamlining internationally educated health professional utilization in the country and kind of helping to streamline some of those things. I think what I'm going to try and do just to help people get a little bit less confused is give you a history of healthcare in less than 5 minutes. So I've been working on this for the past little while, so we'll see how it goes. So if you think of society as like this fertile soil that grows our different systems, it really just has two parts that help to fertilize the soil. The first is a viable economic system, and the second is a strong social fabric. So you have to have some way of exchanging value that's sustainable. And then you also have to have people tied together through some type of vision, purpose, et cetera. And if you look at the social determinants of health, almost all of them have direct correlations and sometimes causations related to either the economics of the social determinant or its impact on social cohesion. And so from this soil, social cohesion and economic viability grow different systems like health and education, social supports, et cetera. And from time to time, we have ebbs and flows of how fertile this soil is. Obviously, a lot of us know that the soil is pretty arid right now. And as a result, our systems are really suffering. The second part of kind of explaining the history of healthcare is really defining what it means to be healthy. And this is probably the problem before this problem, is we haven't identified what it actually means to be healthy. So a lot of you have probably read that networked health document that's been passed around for the last 20 years, I believe. It has an amazing definition of health, which is the inability of you to manage your chronic disease in the context of your community. And so being healthy is not using the healthcare system, essentially. It's when you're depressed, you have a person to talk to in your family or a close social circle that you can work through kind of that ebbs and flows of, mental health. If you have COPD, you're still able to do your day-to-day activities. If all you want to do is, pick up your grandkids, walk from your couch to, the kitchen so you can wash dishes. These sorts of things are what it actually means to be healthy versus, this paradigm where being healthy is the absence of disease, which is a much less practical definition, in my opinion. And so what's the role of healthcare? Well, it's really when the community is unable to help you. So you have these breakthrough moments where you move over to the healthcare system, but the intent is to actually bring you back to your community for you to live and exist, because it's better for you and it's also better for society for you to actually manage your day-to-day living there. The healthcare system has a variety of different roles. It has that breakthrough moment where you kind of get treated and then resolved and then you head back. Sometimes you need a more consistent longitudinal going back and forth between the system. If you have a chronic disease, sometimes you end up leaning on the healthcare system much more than you do on your community, things like end-stage terminal disease like cancer or other things. And so in this context, I'll go to the history of healthcare. So when public healthcare first started, what it essentially was going to your local clinic or hospital. There was no transfers to other locations. There was no multi-jurisdictional, transplant networks. It was more or less you went to the clinic or hospital. If you couldn't get the care that you needed, then that was kind of it. Now, over time, demand rose and public investment rose. And so the healthcare system, when it was first kind of scaling out, literally mirrored what happened in each hospital or clinic and simply duplicated it. And so every hospital or clinic would fix hips. Every hospital or clinic would have an inpatient psychiatric service, et cetera, et cetera. Now, in the late 90s, early 2000s, we ran into resource limitations. We ran out of the number of people that we actually needed to people each one of those FTEs, whether it was physicians or other allied providers. We ran into restrictions on funding, and we ran out of space. And so as a result, in the late 90s, early 2000s, we started to segment our systems. You started to have one place that would do all your trauma surgery, another place that would do outpatient internal medicine, another place where you might have inpatient hospitalist care run by a family healthcare team. And so that was okay for a while. And then patients started to kind of move around more than they usually did. I live in Grand Prairie. I've been down to Calgary and Edmonton for healthcare. If I run into a problem in Ottawa, Ontario, I'll go see a doctor there. Much more mobile than I've ever been. Providers have also become hypermobile. And so despite the changes that have happened in our healthcare system, we still end up approaching workforce planning, surgical services, community care, et cetera, in the same way that we did historically. If we lacked access, we'd simply open a new facility. If we had increased complexity, we'd simply create more specialization and segment our services so we could consolidate those people, those equipment in those places. And as inefficiency and decreased efficacy rose, we'd adopt technology to try and modernize to work our way through these problems. Now, the issue with each one of these things is that the more that you scale by opening facilities, the more you fragment the system. Just like Dr. Bourgeault had mentioned, we don't actually have a clear idea where everyone is. We don't know how many family physicians practice longitudinal care. We don't know the difference between a family physician who works in Grand Prairie, where I live, a city of 70,000, where a person will provide longitudinal care, work in emergency, provide palliative care, deliver babies, and act as a hospitalist all within a week, right? Versus, whether or not anesthesiologists like myself doesn't just provide anesthetic services to adults, but also to small children or other types of subspecialty work. We also don't have a clear idea of where our health assets are. We don't have a consolidated list of all clinics and hospitals in Ontario that's real time. We have these time delays where we don't update our lists for 1 to 2 years. And so as a result, our fragmentation, this over-segmentation, and this really uneven modernization have all led to worse interoperability, which is really at the core of our health human resource crises. So to some degree, I do agree with Dr. Dubinski that it is a bit of a distribution problem, but we actually don't even have the data to know if you're right or not, because we don't have a consistent count, And so I personally define the definition of shortage as showing up to work and not being able to get the healthcare services that you're supposed to have at that location. A very pragmatic definition. If you're supposed to show up and provide emergency services, if someone has a heart attack and they go to your emergency room and it's closed down because you don't have the services that you need, that by definition is a shortage. And so the question that we now have is, how do we realign a lot of these things that don't work anymore? And I think the first step in all of that is to get some clarity that in the arbitrary nature of HHR, we have to decide on shared definitions. That's kind of the first place to start. The second is to recognize that our past solutions are actually our current problems. As long as we have a knee-jerk response that if you don't have enough access for surgical care, you simply open a non-hospital surgical facility, that's just creating more problems. It's creating more fragmentation. The third part is we have to start thinking about consolidation in our system. How do we take this over-fragmented, over-segmented, uneven, modernized system and bring it in under a similar sort of vision, governance, and coordination and collaboration? And so as a result, that's really why the CMA has started to focus on the areas of impact that we think will actually change things. For example, pan-Canadian licensure by itself will not solve everything, but it leads us to different conversations. If suddenly you have pan-Canadian movement of physicians across multiple jurisdictions, you're now going to have to confront why we have different privileging at every single hospital, even within the same province. We're going to have to confront why we have such a gap between family physician pay and specialist pay, even though the environment of providing certain volume-based services has shifted considerably as far as complexity and time. We're going to have to confront why we have consolidation of so many health professionals in places like Vancouver, Toronto, and Montreal, while we suffered to have people in more rural and remote locations. We're going to have to create databases where we actually do track everyone and have more information. It's always a surreal moment when I go on Facebook and it gives me a recommendation on what to get my kids for their birthday, but the health system has no idea how many physicians work inside a catchment or what they do with any sort of nuance. And I think the very last point that I'll make is that the system has to treat providers like people. We know why people move from rural locations. They move because they're unhappy because of their work. They move because there's a personal catastrophe, like a divorce or a sick family member, or certain things happen in their life that are totally predictable. Their children have graduated high school and now they're thinking about moving again. Now, we also know people move to these under-resourced places for the same reasons. You're highly mobile after you graduate. You're highly mobile after one of these traumatic situations. You're highly mobile after you start to wind down your practice and you think about doing locums as well. And finally, just we don't have 100% bandwidth capacity across the system for every single provider. And if we can create a data system that helps us match what people can give with what's actually needed, I think we have a real chance of getting a better redistribution, like it's been mentioned with the previous two presenters. So thank you very much.
Thank you very much, Dr. Lafontaine. So we'll move now into kind of the question and answer period. And what I'm going to do, we have about half an hour left for this open discussion period. I think what I'm going to do here is I'm going to try to blend and synthesize a little bit of not only your comments, but what's been filtering through the chat. And I thank everyone for the robust discussion, and particularly Dr. Bourgeault for your replies in the chat. What I'm hearing as we start to discuss these issues, what I think came up in everyone's comments here is that data collection and the use of nuanced data is a massive problem when we think about HHR planning in Canada, that we're perhaps in a bit of a desert right now when it comes to that. My question for the panelists is, are there models of data collection and implementation plans, maybe that next part's a bit too broad, but that we can look at internationally in other jurisdictions, even at the level of some provinces might be doing it better than others? Are there places we can look for best practices, or are there best practice models that we're aware of that we would want to implement? Dr. Bourgeault, go ahead.
Great, thank you. It's almost like I planted that question, so that's wonderful. So first of all, this is doable. This is not rocket science. We can get standardized data across jurisdictions, across practitioner groups. I mean, just let's start someplace. They've started in Ontario. They've got standardized data across practitioner groups. I mean, they have some data elements that they need to add, Indigenous identity, being an important one, racialized identity. And so I would start there. Where is this happening? So they've invested in a minimum data standard in the United States. And so you can go to a HRSA dashboard, so HRSA dashboard in the United States, to be able to see by sector, primary care, behavioral health, which is what they call mental health care, older adult care. You can see across different practitioners, the density of workers by state, and how that compares to supply. It's a bit of a clunky tool, right? But it gets you started. It gets you started having conversations about, particular areas in your state. Where are the challenges? And they've got some different scenarios. And every month they do an update. They do an update of the data and they add more tools to that. So that's definitely aspirational. Australia also, they have a similar tool called the Heads Up tool, where you can drill down into particular jurisdictions and highlight, as Alika said, where are the facilities, where are the different service providers, and you zoom in to a particular jurisdiction. I mean, are these going to solve all the problems? No, but it gets you started having an informed conversation about what the solutions are. Again, planning is about more than just modeling data. But we absolutely need that in order not to be flying by the seat of our pants, so that we make really evidence-informed decisions. And let me just say, for us to not make these kinds of investments and not have this planning for a sector that constitutes the top 10 workplace in Canada, it constitutes 8% of Canada's GDP. And I mean, there are other sectors where they constitute much less than Canada's GDP, and we lament about those sectors a lot. And we don't in healthcare. And I find that perplexing, and I'm very curious about it. So for a variety of different reasons, just the work life for physicians and other health workers, being able to access this, from patients and communities, to support them. And from an economic perspective, none of this makes sense. And so I think that there's been some good suggestions. A strategy, absolutely. The strategy has to build standardized data for localized planning, building capacity, and the tools that we need for that. This is all doable. We just need to invest. Now, what's great news, and Alika can tell us a little bit more about this because I think he knows more about this than most, is that the federal government announced a Center for Excellence in Health Workforce Data. And I think that it has morphed a bit into Center for Health Workforce for Data for Planning, or the Future of the Health Workforce, whatever they call it. as long as there are investments in this area, and that the investments really ought to be interprofessional. And I would strongly encourage us to start with the primary care system, because that's the upstream focus in order for us to kind of see the downstream impacts. So those would be some suggestions I would make.
Thank you very much. Do the others have comments or things to add on that front? Dr. Lafontaine?
Yeah, just to expand on some changes that came with the health transfer that was recently announced. So I don't know if it's broadly known, but this recent health transfer was the largest nominal investment in the history of health transfers, going all the way back to 2000. And if you look at the second highest, which was in 2003, that's what eventually led 5 to 6 years later to the Canada Health Council and the Wait Times Alliance. And for most of us who were around between 2007, 2008, and 2012, that was a time when things actually felt like they were getting a little bit better. And then the wheels fell off again. And a big part of that was government partners kind of got up and walked away. So some aspects of the health transfer that are important to underline. There's front-end conditions, which are very different than how the health transfers were designed in previous years, which were back-end clawbacks. So what would happen in previous health transfers were, if you weren't aligned with what the requirements were under the deal, you would have some of your funding clawed back, and then you could get it back as you got more aligned. In this transfer, unless you agreed to things, you actually couldn't even access the money. And so to access the Canada Health Transfer, you had to agree to depersonalized data sharing nationally. So that will become a thing. How it will become a thing is up for question, but we are going to enter an era of depersonalized data sharing nationally. There likely will be a persistent patient ID for people across all databases. For both security and for tracking, you have to have a consistent identifier across databases. Otherwise, data is not really useful and very, very hard to realign. We also have a national physician ID in the form of the MEEC number. So we also have the funding of the Medical Council of Canada bringing together that physician registry. And so that's kind of one part. The second part is with the bilaterals. There's a front-end commitment that provinces had to agree to recognize credentialing. That's a step towards pan-Canadian licensure. A lot of people know about the Atlantic Registry that was opened on May the 1st. That locum license across the 4 Atlantic provinces. We are moving in the direction of having pan-Canadian licensure. How it's going to happen is going to be a little bit rocky, but that door is open. I don't think it's going to close. And it's because of the way the funding was designed. And finally, the Center for Workforce Planning. We're currently in the benchmarks and data collection portion of kind of that planning. I think what we're emphasizing over the CMA is that this volume per widget way of measurement. And if you go through the metrics in, say, Ontario with QI, 90% plus of the metrics are how fast can you do something at lowest cost. Obviously you get outcomes based on the way that your data is provided. Why would you care about, a well-functioning cancer care model if they're doing things at a higher price at a lower throughput, right? Because that's the way that we collect our data. And so shifting towards this qualitative data and getting out of this idea that lowest cost is actually the best way of designing a healthcare system, which we all know that built-in efficiency is when we have time to answer patients' questions and actually develop bonds with them and other things. And so I think we are moving in a positive direction.
Thank you, Dr. Lafontaine. Yeah, certainly there's movement at the federal level, which perhaps is cause for some slight optimism. Dr. Dubinski, is there anything you'd like to add before we move on to our next question?
I'm sorry to say yes, because there are so many good questions and so many interesting perspectives that are percolating to the fore. My great regret is that you didn't schedule this for about 8 days, never mind 1 hour.
Never say never, though. I'm sure there'll be more to come.
I just want to shift focus a bit, because one of my personal hobby horses is I don't want to lose sight of something extremely important that we've all alluded to. But I think it's essential that we come back to the fact that this health human resource issue, that our healthcare system has, to me, lost a huge focus on patients, families, and communities. And so much of this discussion and so much of the debate around the resolution of these issues is dominated by professional organizations, politicians, vested interest groups, pharmaceutical firms, and we are insufficiently focused on what's best for patients, families, and communities. So I just wanted to get that thought out there. The second thing is that we have, I think, really lost our focus on the true concept of best practice. I can remember years ago sitting on a panel with, interestingly enough, a Dr. Kaiser, and the question came up about the management of diabetes. And his answer was, at Kaiser, we would just hire more endocrinologists. And my response to that question is, before you make the decision to hiring more endocrinologists, what are you doing around family counseling and antenatal, in fact, pre-pregnancy risk detection for families that are more at risk for having diabetic children? And then what are you doing around monitoring those children early in their lives and ensuring that they have access to dietitians and exercise therapists and nutritionists? And once all of that is rolled together, what plans do you have to measure and monitor their blood glucose over lifetimes? And how quickly and easily can they get access to a nurse practitioner or a physician assistant or another primary care practitioner before solving the problem by saying, this is the number of diabetics we have, and therefore that's the number of endocrinologists we have? It was amazing to me that as internationally reputable an organization as Kaiser had that kind of approach to human resource planning. And the last thing I would say is, we have to think a lot about accountability. In my consulting life, this may seem like a trite or simplistic example, but I would say, having consulted with literally 250 to 300 hospitals across this country, it was unusual, exceptional. In fact, I would say there may have been perhaps 1 or 2% of those organizations where the operating room that was scheduled to start at 8 o'clock started at 8 o'clock. Alika may have a different perspective in Grand Prairie. I freely admit I haven't been there. But if you take the average hospital that has, let's say, 6 operating rooms and say that each one of them starts at 8:10 instead of 8 o'clock every day, that's an hour of operating room time that's staffed, equipped, and ready to provide patient care that's being wasted. That's 5 hours a week. That's 260 hours a year. That's enough time to do another 100 hip or knee replacements. So before we start talking about long wait lists and difficulty getting access to care, we really need to think about this accountability piece. How accountable are we holding individual practitioners, groups, hospitals, and organizations for effectively using the resources that they already have?
I think one of the things that I've recognized, having talked to hundreds of people this year, is that people do what is logical to them in their situation. And I'd say that the people showing up at 8:10, there definitely are a proportion of folks that are just showing up late because they're late. But a lot of folks show up late because the patients aren't ready on a consistent basis. The nurses haven't finished their morning kind of review. At most hospitals, I mean, you're having a bed meeting at 10 a.m. How does that make any sense? You know, you should be deciding that before the next day turns around. People don't go around and discharge patients from the floor until late morning, early afternoon. And so I think that the cultural norms that we have in Grand Prairie, we used to have days where we'd fly through, 12 general surgery cases. Why did that happen? It wasn't necessarily because we started at 8. It was because for turnover, I mopped the floors and then I ran over and I grabbed the patient because the nurse was opening and I knew I couldn't do that task. It's when you have task shifting, just like you were talking about, Dr. Dubinski, when you have people working in a team and sharing, that's where the real magic happens. I don't know if it happens when we have rote application of rules. And absolutely, we should measure these things. But I think at the core of it, when people feel like they're a part of a community and what they're doing actually matters, I do think people step up because it's just a human thing to do. I don't know if we could enforce that. And I do worry that the healthcare system in general is extremely extractive. And so this work harder, work longer paradigm is a very corporate, shareholder-based, capitalism type frame. And I don't know if that translates into better working environments. And that's really what's driving the burnout and worse care, et cetera.
Thank you, Dr. Lafontaine. I'm going to move us on to the next question, which has been the subject of some chatter in the chat here. But since we are the Canadian Doctors for Medicare, I would be remiss if I did not ask a question around our public system. And my question for the panelists here is, what role, if any, do we see, private, and when we say private here at CDM, we mean, investor-owned for-profit corporations or facilities. What role do we see them playing in the health human resource crisis? Is there any role for them in a potential solution? And I'd be really interested to hear the thoughts of our panelists on that, starting with Dr. Lafontaine.
Yeah, so my comments will be brief. I think there's kind of three parts in the way I think about this now. The first is that you can't have equity in a system without the core of it being public financing, full stop. So on a proportion wise, you always have to have magnitudes more public financing than any of this pay out of pocket stuff. And I'd actually move away from the for-profit idea, because if you show up for work, you are obviously doing it because you get some sort of value-based exchange. We're better off saying pay out of pocket, in my opinion. The second is that we actually do have the most efficient economic model in Canada. So what's the most efficient insurance system is the one where everybody's included, because you balance off your highest and lowest risk and everybody in between. And so the third part is, if we have the most efficient model from an economic standpoint, why is it not efficient? And the reason is because the people who move markets, the people who have the most resources to deploy and who can change legislation and policy, et cetera, are making bad decisions. And so it's governments that really need to step up, be a part of the conversation, and actually move things in a direction where we can do something different. Without governments on the table, nothing we do is going to change anything, because we're not the market movers. We're just people that work in the system.
Yeah, I'll add 2 points. Number one, privatizing a service never increases the capacity of the health workforce to provide those services, ever, full stop. So it's not going to increase the capacity. It will not. That's just magical thinking. Number two, moving services into the private sector moves data into the private sector. And we lament about the privacy of data in the public sector, which is important. I don't want to negate the importance of that. But there are data that are harnessed, scraped, algorithms based in the private sector, and that seems to be a Wild West. So the more that you move providers, services, which means you move data into the private sector, the less likely you're going to have data for planning. And I mentioned this in the chat. Those healthcare practitioners who are working primarily in the private sector, so oral health providers, mental health, substance use health providers, largely in the private sector, it is really difficult. I'm not going to say it's impossible, but it's incredibly difficult to really capture the data on what it is that they are doing, at what capacity for planning. So yes, let's start where we have the data in the public sector, but let's be mindful that these are the consequences of privatization. Again, number one, it does not increase capacity. And number two, it privatizes the data, and data are so needed right now.
I may be the only person on this webinar who's actually old enough to have been a patient before the days that public insurance was available in Canada. When I was a child, hospital-based services were covered by insurance, but physician services weren't. And having been raised in a family that could barely afford rent and food, and having been a patient who needed a number of medically necessary, I will hasten to add, surgical procedures as a child, I have vivid memories of watching my parents go to a physician who, I will hasten to add, was a truly Christian in the connotative sense of the word individual. If my parents had even raised the word money, he would have simply foregone the bill. But most of us are hardworking, honest people who want to take responsibility for our bills. And in a private-public mix or in a private delivered system, people who can't afford it will sacrifice in order to pay their bills. And I don't think anybody should have to. That's just part of my long-held philosophy of life around healthcare. It's my bias, it's my opinion, and I admit it, but I am unshakable on that issue. The second thing I would say is my friend and colleague Reza Dieber would chastise me if I didn't talk about the fact that we often confuse this concept of private and for-profit in healthcare. Every family physician in their office is engaged in a for-profit enterprise that's a private business in a single payer model. So I think we have to be careful around vernacular and definitions when we have this discussion. And then the last thing I would say is that Dr. Bourgeault is 1,000% correct. If you look at the literature, look at the evidence around private public systems, there is no question that they are fundamentally skewed and have lots of bad outcomes. They're selective in terms of which patients get to go into the for-profit / private sector, which actually only increases costs in the public sector because they're left with the high-risk patients. They take any complication after a surgical procedure and transfer it to the public system. They siphon staff away from the public system. And much of our reflection on other national constituencies where they have private-public mixes, most of us don't understand very well how those systems work. Most of us don't understand that, for instance, in many of them, family physicians work for an annual salary that most family physicians in Canada would not consider an acceptable salary. They don't reflect on the fact that in many of those constituencies, individuals are forced to buy private insurance to cover the cost of the privately delivered care. There are a variety of factors that are just not well understood in the Canadian environment when we engage in this discussion. And I think, all I will say is if it's not absolutely unequivocally clear is, I think moving to a bigger private involvement, private-public mix, I think is a very flawed solution to any problem we have.
So the topic of our discussion here is on health workforce planning. We are at a critical juncture. We describe the circumstances as a downward vicious cycle. We have excessive workloads that predated the pandemic. We have rates of burnout, which we've never seen before, and they were bad before the pandemic. We have rates of attrition like we have never seen before. And attrition can be in a variety of different things. It's not just leaving the job. It's doing less in the job. It's what we call presenteeism, being at work when you really probably shouldn't be at work. Now, all of that exacerbates it all. So that's what we call the downward vicious cycle. More attrition leads to higher workloads, leads to more burnout, and et cetera, et cetera, et cetera, et cetera. We have to interrupt that. We have a unique and timely opportunity right now. The government has invested in a Center for Excellence in Health Workforce Data. How that is implemented is up for discussion. This is where you have your input. There are tons of things that we need to fix in the health system. Absolutely. Let's take this one because it's a critically important one. And because we have a unique and timely opportunity. So I would encourage everyone here after the webinar, what is it that you can do to impact that Center for Excellence and how that's going to be implemented, to take into consideration the conversations that we've had here and will need to continue to have, right? We are but 3 voices who've studied this, but everybody has a particular experience, but put pressure on that, right? To really reflect leading practices, what's happening elsewhere, what do we need, a national strategy, structure and culture of health workforce planning that's interprofessional, evidence-informed moving forward.
I think the only thing that I might add to this really great conversation is that we talk a lot about supply without having a clear idea of demand. We talk lots about ratios, but we don't talk about like who needs what. We're training folks for neurosurgery who can't get a job in Canada, but we don't actually have an idea of how many people are waiting on a spinal list or how many people have different diseases that require health services that are undersupplied. And so even when we're talking about surgical wait lists, for example, We talk about queues. There aren't actually queues in medicine. They're these patient piles where a booking office will reach in 24 to 48 hours before and then place you on a list. When you're on a list, you're on a queue. When you know who's before and after you, you're on a queue. If you just know you're in some mound, you're just in a mound, you know? And so I do think with this planning and the sharing of both patient and provider data, you know, getting a really clear idea of the demand that we're trying to satisfy, you know, is really, really important. Even when you look at our demographics, yes, we are moving into a wave of having the elderly need care. That's going to last for 30 years. And then what happens after that? Will we have a gross oversupply in 30 years in areas where people can't actually be employed because there is no population that requires their services? I'm not sure, but we could figure out this information if we actually collect it. And I think we're almost better off not looking at health systems, but looking at, you know, private industry like Facebook, et cetera. I mean, you can micro-target the needs of someone with you know, a variety of different models, et cetera, know exactly what they provide and exactly what they need. And then further, you can incentivize them, just like Dr. Dubinski has mentioned a few times, to better behavior. You know, there's only 92,000 plus physicians in the country. It should not be rocket science to figure out how to map and incentivize those folks to act differently. But once again, unless governments step up and actually make the decisions of doing this, we're going to be in the same kind of arbitrary position that we've been for the last 20 years, where there's good folks like the three of us and those who are on the webinar trying to create change, but we just can't push against the waves in the way that governments can.
I may be getting myself in trouble by admitting to this, but I was one of the people who worked on the Ontario wait time strategy. And I can remember very vividly having a conversation with a group of orthopedic surgeons in a medium-sized Ontario community who averaged 3-year wait lists from referral to consultation, not to surgery, but to consultation. And when I asked them, why is the wait list so long? What's the biggest impediment? As a group of 6, they all answered the same thing. It's the amount of time we spend assessing people with back pain who don't even need surgery. To which my response was, well, what are you prepared to do about that? And they said, we can't help it. The referrals come, we have to see the patients. And I said, have you considered either of these two options? One is offering educational opportunities to the referring physicians in your community to help them better distinguish who needs a surgical referral. And the second is hiring physician assistant, physiotherapist, chiropractor, doesn't matter to me what the discipline is, but somebody who has skills, training, and experience in evaluating back pain and introducing them as an intermediary between the referring physician and you, so you only see the patients with back pain who may in fact be surgical candidates. It was a very heated discussion, but I can tell you that the wait time in that community is now 3 months, simply by introjecting a physiotherapist as an intermediary assessor.
Thank you, Dr. Dubinski. So there was so much to think about from that conversation, and I thank you all. I'm cognizant that we're at the end of our time, but I think we can squeeze in one quick question here. We've talked a lot tonight about malalignment. So malalignment in gender differences across providers, problems with credentialing, urban versus rural, pay differentials between physicians, tasks going to the wrong people, unknown supply and demand, et cetera, et cetera, et cetera. And so I get the theme of misalignment kind of from this conversation. And Dr. Bourgeault, you actually read my mind and kind of pre-answered the question I was about to ask. But just as a final thought from our panelists here today, I wonder if in sort of 2 minutes or less, if you could kind of say, what is one thing you would like our listeners to go forth and advocate for or to do, or what should CDM have on its mind for us? And Dr. Bourgeault, you get a second one because you already gave us the first one for free.
I really want to stress, I think I agree with Alika. There are some things that only governments can do. But, you know, in a spirit of distributed leadership, and everybody has a little bit of power, let's utilize that power that we have to have the next conversation, to have, you know, to send the next email, you know, to create, you know, the next campaign. And thanks that are, you know, people have been putting that into the chat. And again, I think it's so very important for us to take this time, this opportunity of the resources that have been allocated And let's sort of figure out, it's not to say that planning is going to solve all these problems, right? In fact, we wrote a report for the nurses that said, we talked about a triple R approach where you have to focus on retention. You have to keep the people in the system that are in the system. You have to not just forget the people who have left the system. You have to sort of figure out how to bring them back. And guess what? The stuff that's going to keep people in the system are going to bring them back. So, that's a double win situation right there. And then you need to recruit strategically, take this crisis as an opportunity to have much more balance within the health workforce to more fully reflect the population that it's supposed to be, working with. And that's around Indigenous health workers, that's around particular racialized groups. And so that kind of triple R approach, again, starting with retention, not ignoring return, and then strategic recruitment, and then upstream focus on planning, which we've discussed today. Thanks.
Thank you, Dr. Bourgeault. Dr. Dubinski, would you like to head us up next?
Sure. Thank you, Devon. Let me start by sharing with everybody a phrase that I use with all of my students, which is that in all my years of working with government, I have yet to find a government that would put good healthcare policy ahead of getting reelected. So my view around this issue is that we have all deliberately, I think, used the words national health human resource strategy as opposed to federal. This needs to be an integrated discussion across all the provinces that obviously needs government input and government representation. But the solution will not, in my opinion, come from government. The solution will come from well-informed, highly motivated, trained, educated, sophisticated academics, members of the public, members of various health professions, trying to solve this problem on a national basis outside of the political constraints and the political desires of individuals. One positive thing happened from COVID, maybe several positive things, but one of the most positive things that we learned is that many people displayed skills, commitment, knowledge, creativity outside the boundaries of their profession. Nurses, physiotherapists, speech language pathologists took on tasks and roles that were not part of their professional description and did it extremely well. So in addition to thinking about numbers, let's think about flexibility, capitalizing on people's true human resource potential, not only to improve the system, but also to address the issue of the health human resource perceived shortfalls, and also minimizing stress and burnout by offering people opportunities to add new roles, tasks, and responsibilities to their contribution to the system.
Thank you, Dr. Dubinski. Last, certainly not least, Dr. Lafontaine.
Yeah, I think I've been thinking lots over the last few months just about why systems don't change. And I think they don't change for two broad reasons. The first is that we cling to the ways that we used to think the world worked, even though the world has changed around us. I think that's one of the big reasons. And the second is because there are people in all of our systems that in this status quo that's creating all this crisis, the system actually works really well for them. And so I think that in moving forward with any of the changes, really encourage people to reflect on those belief systems that push you forward in a direction that just isn't very adaptive to what we need. I think the public versus private frame of saying, there's a moral stance between the two. When people don't have access to care, they don't really care about morality. I'll just be completely honest. And increasingly, that is the lived reality of Canadians. So is it still better to have a public system that has core public financing as a way to drive our system? Absolutely. But we have to change the narrative to align to people's actual problems, And then when it comes to entrenched special interests, we have to identify those folks that the system is working for and spend a lot of time understanding how to overcome that resistance that comes from them. There's a reason why we don't have shared physician data. It's because the data custodians like the way that the system works right now. It works for them in managing their risk. It works for them in the monetization of how they share this data. And so don't get trapped in the way that we used to do things. And I agree fully with Dr. Bourgeault and Dr. Dubinski when they say that the solutions to these things lie in the people that are watching this webinar and are working in this area. Governments need you to tell them what to do.
Thank you very much. All right, well, that brings us to the end, everyone. What an engaging conversation. Like Dr. Dubinski said, I think we probably could have had this going for at least another 6 to 8 hours. We didn't even scratch the surface of entire topics that we could have discussed, but I really, really want to thank you for your expertise, Lynn, Isser, and Alika, because we really are all enriched by not just your participation tonight, but the dedication that you have to studying these issues and advocating around them, because that truly is what it takes to make a difference. And here at CDM, we're just beginning to take up this issue, but I can guarantee this will not be our last word on it. In fact, it's just the start of what I think will be a long conversation. If you're a medical student, a resident, or physician on the call, and you're not a member of CDM, please consider joining us so that you can stay engaged on this topic and on other topics that are important to our healthcare system. We will add a link in the box here. I know our staff were busy behind the scenes taking notes, so there'll be much more to do on this topic. And so we look forward to working with not just our panelists here, but everyone on the call moving forward as we continue to develop and refine our position on these issues and move that into advocacy. So thank you very much, everyone, for being here tonight, and take care.